Your doctor just looked you in the eye, smiled, and said those words you have been working toward for months, maybe years. Your blood pressure is perfect. On 20/80, keep doing what you are doing. You walked out of that office feeling relieved, maybe even proud. You followed the plan. You took the medications. You watched your diet. And now the numbers are exactly where medicine says they should be. But here is what nobody told you as you walked out that door. If you are over the age of 75, that perfect number may be one of the most dangerous things happening inside your body right now. Not because your blood pressure is too high, but because for your age, your biology, and your physiology, it may actually be too low. And the consequences of that are not abstract. They show up at 2 in the morning when you get out of bed. They show up at the dinner table when you stand up too fast. They show up in emergency rooms across this country every single day in the form of broken hips, brain injuries, and cascading medical complications that permanently change the trajectory of a person's life. Tonight, I am going to walk you through exactly why this happens, what the research actually says, what blood pressure targets may make more sense in older adults, and one simple test you can do at home that could potentially prevent a catastrophic fall before it ever happens. Stay with me, because this may be one of the most important conversations about aging and health that many older adults are still not having. My name is Dr. Alric Stone, and over the past several years, I've seen the same dangerous pattern repeatedly in older adults whose blood pressure was treated too aggressively. Before we get into the biology, I want you to understand the scale of what we are talking about. Falls are the leading cause of injury-related death among adults over 65 in the United States. Every year, more than 3 million older adults are treated in emergency rooms for fall injuries. Over 800,000 of those patients are hospitalized, most often for head injuries or hip fractures. And according to the CDC, 1 in 5 hip fractures in older adults results in death within a year. These are not always frail, bedridden people already at the end of life. Many were independent, active adults who had one bad moment, 1 second of dizziness when they stood up, and everything changed. Now here is the connection many people never hear about. A significant number of these falls are associated with blood pressure dropping too low at certain moments during the day, often in people taking medications prescribed with good intentions, targeting numbers that may not fully account for advanced aging physiology. This is not fringe medicine. This is not internet mythology. This is peer-reviewed research published in major medical journals, and it has been reshaping how geriatric specialists think about blood pressure management for years. The problem is that medical information moves slowly. Research takes years to influence guidelines. Guidelines take years to influence everyday clinical practice. And during a rushed 15-minute appointment, nuanced conversations about age-specific physiology often never happen. That gap is exactly what we are going to close today. Let me tell you about a large-scale study that changed how many geriatric specialists think about blood pressure in older adults. Researchers followed more than 15,000 adults over the age of 75. This was not a laboratory population of perfectly healthy volunteers. These were real-world patients, people with diabetes, people who had survived strokes, people living with heart failure, people managing chronic kidney disease. In other words, the exact kinds of patients seen in clinics every day. The study tracked these patients for 5 years and divided them into groups based on systolic blood pressure, the top number in a reading like 130/80. The groups were below 120, between 120 and 130, between 130 and 140, between 140 and 150, and above 150. When researchers examined outcomes, including falls, hospitalization rates, kidney injury, and overall survival, the results were striking. The group with the lowest mortality and the best overall outcomes was not the group below 120. It was the group between 130 and 140. Patients whose blood pressure was aggressively pushed below 120 experienced significantly more serious falls requiring hospitalization. They also showed higher rates of acute kidney injury, and overall mortality was higher compared to patients whose systolic pressure stayed moderately higher. Now, this does not mean high blood pressure is harmless. Patients above 150 still showed elevated stroke and cardiovascular risk, but the data strongly suggested something critically important. In adults over 75, danger exists at both extremes. Pressure that is too high can absolutely be harmful, but pressure pushed too low may also create serious risks, especially for balance, brain perfusion, kidney function, and fall-related injuries. For many older adults, the safest range appeared to sit somewhere between approximately 130 and 145 systolic, rather than aggressively targeting numbers below 120. That changes the entire conversation. To understand why these numbers matter so much after age 75, you need to understand three major biological changes that happen with aging. These changes fundamentally alter how the body handles blood pressure and how it responds to blood pressure medication. The first change, arterial stiffness. In a younger body, arteries are flexible and elastic. When the heart pumps blood forward, vessel walls expand slightly and absorb pressure smoothly. That elasticity helps maintain stable circulation even at moderate blood pressure levels. But aging changes the physical structure of the arteries. Over time, vessel walls become stiffer and less compliant. This process is called arteriosclerosis. It is a natural part of aging. A younger artery behaves like a flexible rubber tube. An older artery behaves more like a rigid pipe. Here is why that matters. When arteries stiffen, the cardiovascular system often requires somewhat higher pressure simply to maintain adequate blood flow, especially to organs like the brain that sit above the heart and depend on constant circulation against gravity. In some older adults, a systolic pressure around 130 or 135 may be providing barely adequate circulation to the brain. Push that pressure down too aggressively with medication and blood flow may temporarily become insufficient during standing or movement. The cuff reading may look beautiful, but the brain may not be receiving the circulation it needs. The second change, baroreceptor sensitivity decline. Your body contains tiny pressure sensors called baroreceptors. They constantly monitor blood pressure and help stabilize circulation when you change positions. For example, when you stand up quickly, gravity pulls blood toward your legs. Baroreceptors immediately detect the drop and signal the nervous system to tighten blood vessels and slightly increase heart activity. This stabilizes blood pressure before symptoms appear. In younger adults, this response happens incredibly fast. But with age, baroreceptor sensitivity declines. The sensors become slower. The correction mechanism becomes delayed. That delay may only last a few seconds. But during those seconds, blood pressure can briefly crash when an older adult stands up. If baseline blood pressure is already running low because of aggressive treatment, those few seconds may be enough to cause dizziness, blurred vision, loss of balance, mental fog, or sudden weakness. This condition is called orthostatic hypotension, and it is extremely common in older adults. The third change, altered drug metabolism. At 75, the body processes medication differently than it did at 45. Kidneys filter more slowly. Liver metabolism changes. Body composition shifts. Medication clearance becomes less efficient. The result is that a blood pressure medication dose that once felt perfectly manageable may gradually become much more powerful over time, even if the prescription never changed. This is why some older adults suddenly begin experiencing side effects after years on the same medications. The medication did not change. The body handling it changed. Let me show you how this can play out in real life. A 77-year-old woman goes in for a routine appointment. Her blood pressure reads 148/88. Following standard guidelines, her doctor prescribes medication. A few months later, a second medication is added because the numbers are still considered mildly elevated. At the next appointment, her reading is 121/76. Everything appears excellent. Her chart looks perfect. But over the following weeks, something changes. When she stands up from the couch to answer the phone, her vision briefly narrows. When she gets up from the dinner table, she instinctively grabs the back of the chair. When she wakes up at night to use the bathroom, she pauses for a moment before walking because she feels slightly unsteady. She mentions this at her next appointment. She is told it may simply be part of aging, but inside her body, something very specific is happening. Her sitting blood pressure of 121 looks completely normal on a cuff. But the moment she stands, her pressure may be dropping dramatically, sometimes into the low 90s. For several seconds, her brain receives substantially less blood flow. Not enough to cause a stroke, not enough to cause immediate collapse, but enough to impair balance, coordination, and visual stability. And this may happen repeatedly throughout the day. Every trip to the kitchen, every nighttime bathroom visit, every moment she rises from a chair. She is now one badly timed episode away from a catastrophic fall. And here is the difficult part. On paper, she appears to be a treatment success. Her blood pressure is controlled. Her chart looks ideal. Her physician followed the standard approach correctly. The problem is that generalized targets may not fully reflect the physiology of a 77-year-old cardiovascular system. Most physicians do not routinely test for orthostatic hypotension unless patients clearly report symptoms. And many patients never report symptoms because they assume dizziness or brief instability is simply normal aging. But this condition is measurable, and you can screen for it yourself at home. The test is called orthostatic blood pressure measurement. Here is how to do it. First, lie flat on your bed or couch for 5 full minutes. Do not rush this part. Your circulation needs time to stabilize. After 5 minutes, while still lying down, take your blood pressure and write the numbers down. Now stand up completely. Do not sit on the edge of the bed. Stand fully upright. Within 1 minute of standing, take a second blood pressure reading. Write those numbers down too. Now compare the readings. If your systolic pressure, the top number, drops by more than 20 points when standing, that is considered clinically significant orthostatic hypotension. If your diastolic pressure, the bottom number, drops by more than 10 points, that also matters. Here is an example. Lying down, 124/77. Standing, 97/63. That is a 27-point drop in systolic pressure, which means every time this person stands up, the brain may briefly receive inadequate blood flow. that dramatically increases fall risk, and many people never realize it because their seated clinic reading appears completely normal. If you discover this pattern in yourself, write the numbers down and bring them to your next medical appointment. Ask your physician directly whether your blood pressure targets or medication doses should be reassessed in light of orthostatic hypotension. A reliable home blood pressure monitor usually costs between $25 and $40. For many older adults, it may become one of the most valuable health tools they own. Based on current evidence focused specifically on older adult populations, many geriatric specialists now favor age-adjusted targets rather than a universal one-size-fits-all number. Adults 65 to 74. For healthy, active adults in this range, systolic pressure between approximately 130 and 140 may provide strong cardiovascular protection while still maintaining adequate organ perfusion. Adults 75 to 84. For many adults in this group, evidence increasingly supports systolic targets around 135 to 145. At this stage, arterial stiffness and orthostatic instability become much more common. The goal shifts from aggressive lowering to balanced protection. Adults over 85 or physically frail adults. In more vulnerable adults, systolic pressures between 140 and 150 may often represent a safer and more realistic balance. At advanced ages, preventing falls and preserving independence become critically important priorities. Now let us discuss the bottom number, diastolic pressure. There is an important lower limit many experts pay close attention to. Diastolic pressure consistently below approximately 65 may reduce blood flow to the heart muscle itself. During the relaxation phase between heartbeats, the coronary arteries fill. If diastolic pressure becomes chronically too low, the heart may not receive adequate circulation during that phase. So even if systolic pressure looks excellent, persistently low diastolic numbers deserve a conversation with a physician, especially in older adults. This is not about blaming doctors. Most physicians are working inside a system that often leaves very little time for individualized discussion. Many major blood pressure guidelines were originally built from research dominated by middle-aged populations. And for younger adults, lowering elevated blood pressure absolutely reduces the risk of heart attack and stroke. The challenge is that older adults are biologically different. An 80-year-old cardiovascular system does not behave like a 45-year-old cardiovascular system. Over the past decade, research focused specifically on elderly populations has increasingly shown that overly aggressive blood pressure reduction may create unintended harm in some older patients. But translating research into guideline updates takes years, and translating guidelines into day-to-day clinical behavior takes even longer. During a short appointment, physicians are often simultaneously managing diabetes, cholesterol, arthritis, kidney function, medications, and multiple chronic conditions. Nuanced conversations about individualized blood pressure targets sometimes never happen. There is also a deeply ingrained medical instinct involved. For decades, physicians were trained that lower blood pressure is almost always better. And in many situations, that remains true. But aging physiology changes the equation, which means the safest target for one patient may not be the safest target for another. That is why individualized care matters so much in older adults. Step 1. Use a home blood pressure monitor and keep a 2-week log. Step 2. Perform the orthostatic test. Check blood pressure lying down, then again after standing. A significant drop may be important information for your doctor. Step 3. Pay attention to symptoms such as dizziness, weakness, blurred vision, mental fog, or instability when standing. Step 4. Ask your doctor what blood pressure target is right for someone my age and health condition. Step 5. Speak up about medication side effects. Dizziness, fatigue, and balance problems should never be ignored. Here is the bottom line. For many adults over 75, lower is not always better. Blood pressure that is pushed too low may increase the risk of falls, balance problems, kidney injury, and orthostatic hypotension. The safest target often depends on the individual patient, not a universal number. If you are over 70 and taking blood pressure medication, start a home monitoring log, do the orthostatic test, and discuss your personal blood pressure target with your physician. Because the goal is not just a good number on a screen. The goal is to protect your brain, protect your kidneys, protect your mobility, protect your independence, and maintain the highest possible quality of life. If you found this information helpful, share it with a friend or family member and subscribe for more evidence-based health discussions.